the MACRA final rule and what you need to know to successfully navigate the program. So the final rule was released by CMS in mid-October and addresses those long-awaited questions that we had about exactly how MACRA was going to be implemented. But the challenge was the ruling was over 2,200 pages, and I don't know about you, but I don't have the time in my day to go through that. So what we've done is we've culled it down into the important details to help you understand how this ruling is going to impact your practice in 2017 and beyond. And I'm pleased to have Elena Campos with us today to lead the discussion and the presentation. She is our go-to person on MACRA and other government regulations, and I'm really looking forward to having her discussion today and learning a little bit more about what that rule means for us. But before I pass it over to Elena to get started, there are some typical housekeeping notes that I'd like to go over. Today's session is being recorded. It will be made available to participants after the event. So after the event, you're going to receive an email with a link to the recording as well as a link to the PDF slides that we're sharing with you today. The information is extremely important, so we do encourage you to share this with colleagues and coworkers that could not join us for the live session. Because we have so much content to cover, we may not have a lot of time at the end of the presentation for questions, but we do want you to submit your questions. So I encourage you to use that chat or Q&A tab, submit your questions. If we have time at the end of the presentation, we will absolutely address them. If not, we will do a follow-up email communication with you. On your screen, you should be able to see the slides for today's discussion. If you are interested in viewing a full screen mode, there is a double arrow in the upper right-hand corner of the slide screen. Just click on that and it will bring up a full-size presentation for you. Okay, so I'm going to wrap up. That's it for my housekeeping notes. So without further ado, I'm going to pass the presentation over to Elena to get us started. Elena.
Thanks so much, Allison. Appreciate it. And welcome, everyone. Thank you so much for taking the time out of your busy schedules to join us for this education session. As Allison said, this rule was over 2,000 pages long. There's so much information out there coming from so many different places regarding this rule and regulation and other regulatory items. It's very difficult to sort through it all. So I've taken the most applicable information to our eMDS customers regarding the Quality Payment Program, or QPP, and put it in this presentation. If you have questions, though, regarding regulatory items, feel free to email me. Our emails are first initial, last name, at eMDS.com. There's no dash anymore, so mine would be ECAMTOS at eMDS.com, no dash. Again, feel free to email me questions or concerns regarding regulatory matters. If I do get emails regarding typical support questions, I will refer you to your product's respective support team. But there are no silly questions. There are no dumb questions when it comes to regulatory items. Feel free to ask. eMDS is here and happy to help. We'll reach out to anyone who needs to help us answer your questions. And as we'll go through this presentation, we're all going to learn how complicated these items can be. So again, feel free to reach out if you need help. And as eMDS has grown over the past couple of years, we're so proud to represent and support our customers on the several platforms and applications we now have in the organization. There's a great deal of change coming our way as an EHR vendor, and as you, the clinicians. We're being bombarded, it seems like, at every turn with new requirements, but eMDS is going to continue to remain informed on the latest updates regarding legislation and regulation. We're very active members of the EHR Association, and comment regularly with regarding bills and legislation that are released. So we have frequent conversations with the Office of the National Coordinator regarding certification items and with CMS. We'll make sure that the functionality in applications is the most appropriate in order to handle these different regulatory items and to help support all of our customers in understanding all these changes. We are committed to ensuring that our customers have the EHR functionality required to meet a variety of quality programs and to navigate the rough course ahead. But in doing so, we'll be partnering with best-of-breed companies for functionality that falls outside of the eMDS core. This will allow us to provide solutions more quickly and solutions that are going to be maintained over the long haul. We have to make sure that the customers, no matter what platform, have a great solution to meet all of these needs. And so we are on the lookout for always the best way to help. So today we're going to focus on CMS's final rule, and I'll say it's a final rule, but it has a comment period regarding MIPS and the Quality Payment Program, or QPP. Now, I will be talking quite a bit about a lot of acronyms, so I will try to state exactly what those acronyms stand for. As you know, CMS is it really likes acronyms. So just to start out with a little bit of background, MACRA. MACRA stands for Medicare Access and CHIP Reauthorization Act. And again, this is an acronym within an acronym. CHIP is Children's Health Insurance Program. So again, MACRA is Medicare Access and CHIP Reauthorization Act. This bill was passed in 2015. Under this bill, the fee-for-service payment system was changed to be more of a pay-for-value. So we're moving away, under MACRA, we're moving away from fee-for-service. We're moving toward payment for value. MACRA also repeals the sustainable growth rate, which is something that caused quite a bit of stress each year, threatening to have a large percentage cut in Medicare payments to clinicians. So we don't have to worry about that anymore under MACRA. But MACRA does do quite a few other things. And so I want to start out with a clarification on Medicare versus Medicaid and what the difference is under the MACRA ruling and regarding the quality payment program related to MACRA. The MIPS program under the quality payment program applies to clinicians who see Medicare Part B patients. And this will begin in 2017. Now, Medicaid clinicians, or clinicians that see Medicaid patients, will still have to report to their meaningful use requirements exactly the same as they had before. So clinicians seeing Medicaid patients still report to their respective state MU programs, or the meaningful use program that they had been following prior to the release of MIPS. Clinicians that see Medicare patients, and especially Medicare Part B patients, those clinicians will fall under the MIPS program, which is different than the Meaningful Use EHR Incentive Program. If you are a clinician that sees both types of patients, a lot of care has to be taken into the program and each different program's requirements, because both will still apply to those clinicians. So this is a huge undertaking for those clinicians that see both types of patients. Today, we're talking about clinicians that see Medicare Part B patients. Those clinicians will fall under the MIPS requirements. So the Quality Payment Program, which has been initiated under the MACRA bill, is set to achieve certain goals listed here. They are, if you'll notice, trying to maximize participation. So you will see that it's very interesting if you take a look at the final ruling. They are estimating a huge percentage of clinicians will fall under these rules. And they're trying to increase that number. They've actually changed the definition of who falls under these rules by changing the text of eligible provider. They are now using the term eligible clinician, and in doing so, they've opened up a much wider range of clinicians that will fall under these rules. There is also a large push for the adoption of advanced APMs, or advanced alternative payment models, and we'll go over that a little bit later. At the bottom, you'll see a website, qpp.cms.gov. This site has a lot of very helpful information. If you're looking for some more details, please check that out. I'm sure you'll find that it's very helpful. They also have a really nice tool to look up the different CQMs and the options there. So check that out. A little bit more about the Quality Payment Program. Again, this is the program that has been initiated under the MACRA bill. It gives clinicians two choices: either participate in the MIPS program or participate with an advanced alternative payment model. They are expecting quite a large percentage of clinicians to fall under this requirement. So those clinicians will have these two options: either select MIPS or select an advanced APM to participate with. So we'll start going into what's required with the MIPS program. The MIPS program, or the Merit-Based Incentive Payment System, combines a lot of different quality programs into this one. So PQRS, or the Physician Quality Reporting System, the Value-Based Modifier, or what they're showing here is VM, and the Meaningful Use EHR Incentive Program are all slightly modified and combined into this one MIPS program. The MIPS program begins on January 1, 2017. So the last performance period for these individual reporting programs, so PQRS, Value Modifier, and MU EHR Incentive Program, all of those end at the end of 2016. So 2016 is the last reporting period for those individual programs. And then the payments for PQRS would end in 2018. So at the start of 2018, those are all done. A little bit more about timeline to clarify. In 2017, we begin the performance year, or the data gathering year, for the MIPS program. And as we're accustomed to for testing or data submission, that will occur by March 31st of 2018. We'll be expecting feedback toward the end of 2018, and then on January 1, 2019, clinicians will begin to see their payment adjustments. The MIPS program is broken up into 4 categories: quality, cost, improvement activities, and advancing care information. These are to help clinicians to move to a performance-based or value-based payment system, and to help support and align advanced APMs. There's a lot of flexibility for 2017, so we'll start talking about those details. First, though, let's talk about who's eligible for MIPS. Any Medicare Part B clinician that bills for more than $30,000 in reimbursements, or that sees 100 or more Medicare patients in 1 year, is going to fall under the MIPS requirements. So this includes all of these clinicians listed below. This goes into effect January 1, 2017, and is set to remain for the reporting year 2018. Now, beyond that, the Department of Health and Human Services does have the flexibility and is anticipating that they will open this up to include even more clinicians, or a wider variety of individuals or organizations that see or give care to patients. So for the 2017 reporting year, which is the one coming up very soon for us, Medicare Part B clinicians billing more than $30,000 a year, providing care for 100 or more Medicare patients a year, will fall under these requirements. There are a few exceptions. If a clinician is newly enrolled in Medicare, they are exempt. If they're below the low volume threshold, so seeing less than 100 Medicare patients or receiving less than $30,000 a year in Medicare Part B reimbursements, or if the clinician is involved with an advanced APM. So we'll talk about advanced APMs toward the end of the presentation to give you more details on that. There are 2 options for the MIPS program reporting. Clinicians can report as an individual, or they can report as a group. Under this program, CMS is planning for the penalties to fund the incentives. So we're starting out right away in 2017 with a possible negative 4% penalty or a 4% negative payment adjustment if a provider or clinician does not participate. And then you'll see that that penalty goes up each year. It's quite a large penalty, and we'll have to keep a real close eye on this and maybe the changes that occur year to year. But it has been stated several times from my dealings with CMS that they feel strongly that any clinician that does not start participating as soon as possible will fall further and further behind in knowing how to meet the requirements. So, and as you'll see, when we're discussing the scoring methods further down in the presentation. It's quite complicated. It will take some time to determine which items each clinician would like to report on, and that time, the longer it's put off, the more concern there can be about receiving a penalty. So I'd encourage you to begin looking at the options and start determining which items you'd like to report with and use for reporting, because the longer, the larger amount of time that this is put off, the more difficult it will become. So, a little bit more about the options we have for 2017. In 2017, if you submit some data, and we'll go into more detail there, for the reporting year of 2017, you can neutralize the negative 4% payment adjustment, meaning you can make sure that you are not penalized, or you could receive a small payment, positive payment adjustment. You can also participate in 2017 as reporting for a 90-day period, a continuous 90-day period, to receive a small positive payment adjustment. Or another option is to fully participate and submit data for the entire year to receive, more likely receive a larger positive payment adjustment. So again, in 2017, if an eligible clinician chooses to not participate at all, they will receive a negative 4% payment adjustment. So at bare minimum, in the year 2017, the clinician needs to submit one quality measure or one clinical practice improvement activity, or 4 to 5 of the required advancing care information measures. Now, we'll talk about this again later, but advancing care information measures are very, very much like the former MU measures. So one quality measure or one improvement activity, which these are all brand new, or 4 to 5 previously MU but are now being renamed advancing care information measures. That is the bare minimum for 2017 to make sure that no negative adjustment is placed on the clinician. A partial submission for 2017 means submitting 90 days of data to much more likely earn a positive payment adjustment. So that continuous 90 days needs to occur during the 2017 year, and the data has to be submitted by March 31st, 2018, much like the PQRS or MU reporting program today. October 2nd of 2017 is the last day possible to begin a 90-day reporting period. And the last option for participation in 2017 is to submit a full year of data. This is the highest possibility, this gives the clinician the highest possibility to earn a positive payment adjustment and the highest probability of receiving bonuses. Now, bonus payments are possible. There are a lot of rules behind them, but overall, the thing to remember is that the longer or the more data that is submitted, the more likely the clinician is to receive a bonus. A little more detail on the 4 categories for the MIPS score. Now, under the MIPS program, each clinician will receive an overall score. That score is based on a 1 to 100 point scale, and each of the 4 categories below represent a percentage of that 100 points. So quality for the year 2017 is 60 points. This year, the cost category, in 2017, the cost category is not going to count toward the overall score. Improvement activities have 15% for 15 points, and advancing care information, or formerly the MU measures, those will be 25 points of the overall score. Now, this scoring methodology does become quite complex. Each of these percentages that leads to the 100-point score of the overall MIPS composite score, each of these 4 have their own separate scoring methodologies as well. So there's a lot of scores within scores and different calculations for the different categories. So we'll talk high level about those. And again, this is quite complex. There are no silly questions. So this is something that we'll have to go over several times to make sure we understand, but in the end, we'll have a good understanding of it. Now, I wanted to show this picture to outline a little bit more about what I've been saying regarding the time for which the data is submitted. So a couple of points here on the left. Depending upon how long the reporting period is and how many measures the clinician selects, the total possible score will change. 50% of patients are required to be reported on, and that's including all payers. So that means that 90 days may not cover the full percentage of patients needed for full credit. This is why it's much more likely to receive a more positive payment adjustment and more bonus points for submitting longer periods of time. So if you look on the far left of the picture here, if you submit 0 data, you'll have the negative 4% payment adjustment, but submitting anything will negate the negative payment adjustment or zero that out. If you submit anything, the floor is 3 points, so that will give you at least 3 points. But the more and more the larger amounts of data increase your incentive payment. So as you move toward more amounts of data, you see the incentive going up. And that's basically all that's really showing. So going into one of the 4 categories of MIPS, the first one being the quality score. This is the highest percentage of the MIPS composite score in the year 2017. Under the quality category, a clinician can select 6 CQMs plus 1 outcome measure, and this is something that will, the qpp.cms.gov site will be very helpful with. They have a catalog of all the CQMs to select from, and they state which ones are outcome measures and what the types are. So it's much easier to select which measures that you will want to report in 2017. The next option is to report 11 measures through the GPro web interface. And the last option is to select one specialty measure set. Now, if a specialty measure set is selected, then the clinician is required to report on the entire measure set, whether that's 3 measures or 9 measures. So be very careful about selecting a specialty measure set and be aware of all the rules regarding those specialty measure sets. There can be quite a few different measures included, and that might require work above and beyond the minimum of 6 plus 1 outcome measure that's required. The scoring for the quality measures is different than what we've seen before. So this is a 10-point decile scale, but in 2017, the floor for submitting any data is 3 points. So there is no possibility of getting 0 points for submitting a CQM. The percentage, though, so to clarify, under the MIPS program, each clinician will be graded based upon benchmarks set from clinicians from around the country. Therefore, if 90% of the clinicians in the country are reporting on the tobacco use and cessation CQM, and the clinicians are all doing very, very well, that might alter the score for an individual clinician, even if they're still doing well, but maybe not as well compared to all other clinicians. So, to go on to the bullet point here at the top left, if an individual clinician has 90% of patients in the numerator of a quality measure, but 90% falls in the 80th decile compared to all other providers, that individual clinician will only get 8 points rather than 9 points for the 90% in their numerator. So these scores are based upon comparisons with other clinicians and benchmarks set on an overall scale. But again, the floor is set for 2017 at a minimum of 3 points for any CQM submitted. And the clinicians are required to report on 50% of patients, and that's for all payers. The patient threshold goes up the next reporting year, which is 2018, goes up to 60%. So again, we've got this whole scoring methodology is taken into consideration just for the quality category of the MIPS overall composite score, which will go into the 100 points. Advancing care information. This is formally the MU measures. Under this category, the clinician must use a certified EHR. They do have options to select which measures they'd like to report with. There's a total possible point of 155, but only 100 is needed for the max score here. There's a 5% bonus for any clinician reporting to a registry that is not the immunization registry for their state. And there's a 10% bonus for using a certified EHR. So a little bit more about the ACI score. There's a base score of 50 points, which is an all or nothing amount of points given for attesting to the 5 required measures. There's a performance score, so depending upon how well those measures are, how well the clinician performs, another 90 points is possible. And then there's a possible 15-point bonus for registry reporting and the use of a certified EHR. So then that gives us the 100-point maximum score that's required to receive the full 25 points toward the MIPS overall composite score. Moving on to the next MIPS category, clinical practice improvement activities. This is the category that is completely new, and there is really a huge amount of items to select from. There are the 9 subcategories listed here, but under these 9 categories, there's a total of 90 or so activities to actually report on. Now, for 2017, you only have to select 1, and these are activities that are much like what we've seen in the TCMH program. These are items that are not necessarily present in the EHR as a report that exists today. So these are items that need to be documented for at least 90 days to receive credit. And this documentation that occurs needs to be able to stand up to an audit. So if one of these items is selected, look through the items and see if there's anything that the clinic is documenting today that aligns really well, and that documentation will stand up to a CMS audit. That's probably the best way to make a good selection that doesn't disrupt workflow, and to make sure that you have all the documentation necessary to receive your full point score. There are 2 different point levels for the clinical practice improvement activities. Some are categorized as high point activities, and some are categorized as medium point activities, which the high point activities are worth 20 points, medium are worth 10 points. So there's a grid here to show you what the different options are, or a couple of different options, I should say. And again, these activities have to be documented for at least 90 days. The cost category for MIPS is the one of the 4 that is not going to impact us for 2017. But this is the item that is replacing the value modifier program that is now being called the cost category under MIPS. So this scoring does not impact us for 2017, but the clinicians will receive still their QRUR reports or their quality and resource use reports to let them know how they're doing. And I would expect that this category, of course, will move up in percentage as the years go on under the MIPS program. So again, all of the categories that we just went over fall under the option on the left for a clinician to participate in the MIPS program. So we've got the quality category, the cost category, the clinical practice improvement activity, and the advancing care information category. So those 4 items all are individually scored. Those scores all add up to the overall score for MIPS, equaling a maximum of 100 points, and that will determine the clinician's positive or negative payment adjustment. Now, the other option for participation in the quality payment program initiated under the MACRA bill is to participate in an advanced APM. And advanced is the key word here, so we'll talk more about that. A little bit about APMs. There is quite a bit of involvement with APMs already, and there is a lot of regulation around them. So CMS has, for example, the Medicare Shared Savings Program is an APM, and there are several others. But something to keep in mind is that advanced APMs are a subset of just the average alternative payment model. So if a clinician selects to go the APM route for reporting, it's very important to understand all the details of the APM and to make sure that it is an advanced APM if it's being used as a reporting method to exempt a clinician from the MIPS program. So an advanced APM requires a certified EHR technology. They require the providers to submit quality measures, and each APM is a little bit different. So because each APM is different, all the details of the APM that's possibly under review for a clinician or that a clinician is already participating in need to be understood to make sure that that APM truly does qualify them to be an exemption from participating in MIPS. If the clinician would rather participate in an advanced APM than participate in the MIPS program. Now, participating in an advanced APM can possibly get the clinician a higher reward, but there's also a higher risk related to participating. So that's another thing to take into consideration when learning about all the details for the APM that you're searching for, and to make sure that it's an advanced APM that meets these requirements. Just make sure that all of the details are understood, because there is a greater reward, but also greater risk. Just a little bit more about a QP under APMs or a qualifying alternative payment model participant, which is referred to a lot as a QP. So overall, the decisions that have to be made are looking at if a clinician is not participating with any APMs, they are, which is depicted on the far left, subject to the MIPS adjustments and should participate in the MIPS program to avoid negative payment penalties. If the clinician does participate with an alternative payment model, they are subject to the MIPS program and APM-specific rewards. If the clinician is participating with an advanced APM, they are only going to participate with that APM. They are exempt from the MIPS program, and they can also receive a 5% bonus. So here's just a quick summary here in this picture to help bring this all together to make sure that if there is an APM involvement, that you have to make sure you understand if it falls under the advanced APM or just a regular APM, to understand if the MIPS reporting is still required. So a few key dates to remember regarding alternative payment models. A clinician has to be on an APM participation list at least by at least one of the 3 dates below. Otherwise, that clinician has to report under the MIPS program. CMS has quite a bit of assistance available, including through quality innovation networks or quality improvement organizations, QIOs. And eMDS does have direct contact with several QIOs and QINs to provide assistance through them to customers. There is quite a bit of funding now under the MACRA bill to provide assistance to clinicians. So CMS is ramping up all of these different ways to help everyone understand these quite complicated requirements and to help make sure that there's good education around what types of APMs there are and what the options are. Something I have heard from CMS is that they have recognized that in trying to promote the participation in APMs, they need to open up the registration periods for several of them. So as many of you may know, the CPC Plus program registration period has already closed. And yet, we're seeing through this final rule that CMS is really trying to promote more participation in APMs, which CPC Plus does fall under. So they are opening up those registration periods again, and so we should expect to see that information come back and be publicized soon. Again, the MIPS final rule does still have a comment period. So this is something that you can still tell CMS if you like or dislike. They are asking for comments, and these are the different ways that you can submit your comments regarding this rule. eMDs will be submitting comments through our participation with the EHR Association. I guess our FigMD logo isn't showing, but this is regarding our clinicians that are on the application solution series. If you've already signed up for FigMD for quality reporting, there is also the option to allow FigMD to submit the 2016 data for the EHR incentive program electronically for you. There's a couple different options to select when registering, so they will be doing an outreach if that option was not selected during your registration to ensure that if you need this, that they will do another round of outreach to make sure that you can submit through FigMD if you would like. If you have questions about this, please email them at support@emds.elixirmd.com. And I think we've come close to the end, but there is just about 2 or so minutes to try and get a question. Allison, if there's a question that has been coming up frequently, maybe we have time for one.
So we have had a number of questions that have come in here, and unfortunately we're not going to be able to address all of them before the session ends. In terms of a question that's been repeating, so there's a question about the 50%. Is it 50% of patients seen during the reporting period?
No, it's 50% of patients seen during the year, which is why a 90-day reporting period could be very difficult to meet that threshold. That's why CMS is encouraging clinicians to report for a longer period of time. Again, the minimum is 3 points for each CQM. So at the bare minimum, the clinician can negate or neutralize the negative payment adjustment. But on the plus side, if they do report for a longer period of time and meet that threshold, they can then be much more likely to qualify for a positive payment adjustment.
Okay, thank you. Unfortunately, we do have to wrap up. However, we have all of your questions that have been sent in, and what we will do is